HAI program. I will be your host for today's webinar. Today's webinar is entitled Antimicrobial Resistance in California, Updates on Clinical and Public Health Laboratory Testing. Our presenters today are from the CDPH Microbial Diseases Laboratory and the CDPH HAI program. A copy of the slides and a recording of the webinar will be posted on the CDPH HAI program website, and all webinar participants will be notified when they are available. We will wait until the end of the presentation to address any questions to the presenters. Please type your questions by using the chat or Q&A panels, and we'll make sure to get them answered accordingly. Thank you, and I will now turn the presentation over to Sam Horrick-Schofield, one of the antimicrobial resistant epidemiologists with the HAI program.
Hi, Lynette. Thank you so much for the introduction. So we have a pretty jam-packed schedule today, so I'll go ahead and just start without any further ado. I'll talk a moment about the objectives and the structure of today's webinar. I will be presenting a basic description of AR testing capabilities of clinical laboratories as they're reported to the National Healthcare Safety Network, or NHSN. I'll be followed by Stephanie Abramidis and Peng Zhang of MDL. They will summarize the results of the first year of phenotypic and molecular carbapenemase testing here at MDL, and they'll also be providing some updates on upcoming testing capabilities at MDL. Finally, we'll hear from Matthew Sylvester on illustrating the use of whole genome sequencing to assess relatedness of isolates to inform outbreak response. So to begin with, I'll just talk a little bit about the data source that I'll be using today for the first half of this presentation. The National Healthcare Safety Network NHSN Annual Survey, it's something that all facilities reporting to NHSN, which is pretty much all facilities. They complete an annual survey to describe and evaluate hospital and laboratory practices. So these include basic hospital characteristics like bed size, infection prevention measures, such as the use of contact precautions in certain situations, elements of antimicrobial stewardship programs, and of course, the main topic today, clinical microbiology testing methods and practices. And unless otherwise indicated in today's presentation, all reports are from the 2017 NHSN Annual Survey. Now, there's a lot of information published and out there online about data that comes from the NHSN Annual Survey, and this is just a quick screenshot of a couple of the publications that really inform today's presentation. On the top left, actually, you'll see an example of an online tool, the AR Patient Safety Atlas, that describes some of the antimicrobial stewardship elements that are in place at various hospitals. And if you haven't checked it out yet, I highly recommend just Googling, the CDC AR Patient Safety Atlas, of course, after this webinar is over. So a breakdown of some of the hospitals that reported to the NHSN Annual Survey in 2017, it's 389 hospitals in total. The largest portion were community hospitals, followed by major teaching hospitals. There were also 33 critical access hospitals, and importantly, 22 long-term acute care hospitals. They actually fill out a slightly different survey, but has many of the same elements. And then finally, 10 pediatric hospitals were included in this assessment as well. So to launch directly into some of the questions and data that was collected as part of this survey, the first question that they asked of just long-term or just acute care, short-term acute care hospitals, so not the long-term acute care hospitals I just mentioned, they asked, what is the primary or definitive method used to identify microbes from blood cultures? And over the majority were automated testing instruments, or I'll refer to them as ATIs. Some also used MALDI-TOF-based systems, as well as rapid identification systems, and then just a few used non-automated manual kits. And then they asked about whether your facility has its own on-site laboratory that performs antimicrobial susceptibility testing, or AST. And the vast majority of hospitals, 97%, reported using some sort of automated testing instrument for AST. And when we looked at, whether it's on-site or not, 65% said they have, these services on-site. But among those who said it's not on-site, most of them indicated that they had an affiliated medical center that performed AST for them. The others referred to some sort of reference laboratory for AST testing. Next, the survey asked about antifungal susceptibility testing. So when they asked, does your facility have its own laboratory that performs antifungal susceptibility testing, about a little less than a third said yes. The others replied no. Most of them indicated some sort of reference lab or other category, possibly an affiliated medical center as well, that performs this type of testing if necessary. But drilling down a little bit more, not just looking at, do you have access to antifungal susceptibility testing, but whether or not antifungal susceptibility testing is performed automatically or reflexively without needing a specific order or request for susceptibility testing. This is when a Candida species is identified from a normally sterile site like blood. We actually tracked that trend over time because CDC had published a paper that did something similar from 2011 to 2015. We looked at data from 2014 to 2017. What we saw was an overall increase in proportion of facilities that did some sort of reflexive AFST. The proportions were actually significantly higher than what we saw in the national sort of overall picture. And the green bars represent sort of the raw counts of hospitals, and the gray trend line represents the overall proportion of hospitals that year that reported doing this type of testing. Now, when it comes to antifungal susceptibility testing, I thought this would be a good place to mention that the Antibiotic Resistance Laboratory Network, run by CDC or ARLN, our particular branch is the West Regional ARLN, located in Washington State. They offer routine testing for antimicrobial resistance and pathogens. So just one of these examples of these categories would be confirming Candida species identification using MALDI-TOF, and then also performing extensive antifungal susceptibility testing and providing those results to the submitting lab. This is part of what we call a targeted surveillance program in California. This is a number of select clinical laboratories that have decided to go ahead and participate in enhanced testing for hard-to-detect pathogens. So ARLN supplies the packaging materials, the labels. All of this is at no cost to the labs. And the three main categories that they're looking at are surveillance for carbapenemase-producing Acinetobacter, MCR-positive E. coli and Klebsiella, and Candida. They're looking at Candida auris and just generally looking at multi-drug resistance among Candida species. So these are the sort of three main categories, and if your lab is interested in accessing this type of testing, please go ahead and get in touch with us at the end of the webinar. We'll have some email addresses. So the next questions that we'll go over are about breakpoints, interpretive criteria for determining whether or not a particular bacteria is susceptible, intermediate, or resistant to a given drug. So this is about cephalosporin and monobactam breakpoints from 2009 to 2010. I just wanted to show sort of the older breakpoints and the more current breakpoints. I'll note that the cefepime, to be labeled as cefepime intermediate, this is actually more about being susceptible dose dependent. But for the others, I think this all applies. So these are the updated breakpoints for cephalosporins and monobactams. So when we asked specifically about whether laboratory implemented the revised cephalosporin and monobactam breakpoints, we tracked the trend over time. And as you can see, an increasing proportion, as indicated by the gray trend line, The green bars are an overall count of hospitals that have adopted the updated breakpoints. So you can see we're making quite a bit of progress, and we're doing better actually than I think what you see in the sort of national overall picture. But we still have a ways to go. We're not, we'd like to get to 100%, and we're still hovering around 80 to 85%, using the most updated breakpoints. Next up, we asked about carbapenem breakpoints for Enterobacteriaceae. So again, this is to determine whether something like a Klebsiella or E. coli is susceptible, intermediate, or resistant to a given carbapenem. It's very important for being able to identify multi-drug resistance in a hospital. And as you can see in the more current breakpoints, they have been lowered, thus enabling us to better determine what is, or have a lower sensitivity threshold for what is resistant. And similarly, we see a similar trend as we did with the cephalosporin breakpoints with the carbapenem breakpoints. And these, the gray trend line is from 2014 to 2017, showing the overall proportion of hospitals. We're approaching 90%. I believe in 2017 it was about 88% of all hospitals reported using a lab that used these updated breakpoints. So that's great news. I'm glad we made a lot of progress, but we still need to really reach out to those 12% of hospitals that use old breakpoints and really figure out a way to try to update those interpretive criteria. Unfortunately, we were very excited to recently, in September 2018, be joined by Janet Hindler. She gave a webinar on implementing current breakpoints on your AST system, a step-by-step instructions. And she provided some really excellent supportive materials, including not just PowerPoint slides, but a checklist, a protocol, a worksheet, really a how-to update your breakpoints yourself. It's not the most straightforward process. Requires significant time and effort on your end, but we think it's really important. And all of these materials are available on our website. The address is listed here, or you can always follow up with us afterwards. There's a webinar recording and slides, and of course the other supportive materials. So besides asking about antimicrobial susceptibility testing and carbapenem resistance, the survey also has a number of questions about carbapenemase detection. Now, carbapeenamases, for those of you not familiar, are enzymes that essentially confer resistance to carbapenem antibiotics, and they tend to actually confer resistance to a number of different classes, really creating a hard-to-treat, difficult-to-treat bug. And carbapenemases can also be transmitted between different species. They're readily transmissible in the healthcare environment, and it's really one of the most urgent pathogen types that CDC has designated as part of the antimicrobial resistance prevention strategies. So when we asked about whether people test for carbapenemases, we actually I was a bit surprised. It's a relatively high number and kind of stable over time. The gray trend line shows the overall proportion. The orange bars show the number of hospitals. And you can see we're, between 45 and 50% of hospitals do some form of carbapenemase testing. But when we excluded the modified Hodge test, those numbers really went down. And the modified Hodge test is the most common carbapenemase test out there. It's probably one of the cheapest and most sort of straightforward. Unfortunately, there are problems that have been documented with interpretability. There's some false positives for certain types of CRE. There's also false negatives for certain types of carbapenemase-producing CRE, such as the NDM carbapenemase producers. So modified Hodge test is something we recommend caution when relying solely on the modified Hodge test to determine if something is carbapenemase-producing. And this is a breakdown of the carbapenemase test types that were indicated. And as I mentioned, the majority, I think it was about 90, used the modified Hodge test. Others used PCR-based tests, which are molecular tests. They're able to tell you, not just that a carbapenemase is present, but what type of carbapenemase, whether it's a KPC or NDM or VIM or something like that. And these PCR-based tests can be sort of commercial tests like Veregene, Nanosphere, or Cepheid, carba-r, but they can also be sort of home-brewed PCR tests as well. And there are other tests listed here as well, specifically carba-NP and MSIM are two phenotypic tests, meaning they'll tell you whether or not a carbapenemase is present, not telling you specifically what type of carbapenemase it is. And this is something you'll hear more about from our speakers in a bit, MSIM testing and carba-r testing specifically. And as I mentioned, beginning in August 2017, CDPH MDL was offering voluntary testing or submission for testing of all Klebsiella, E. coli, Enterobacter species, and Pseudomonas aeruginosa that is resistant to at least one carbapenem. And it is possible to test other species such as Citrobacter, things like that, but that has to really be done in consultation with the HAI program before submitting those isolates. And as I mentioned, phenotypic and molecular testing is offered at MDL, which you'll hear quite a bit more about. Now, carbapenemase testing among hospitals not using updated breakpoints is also something we wanted to look at and was actually in some of these national publications as well, because hospitals that are using old breakpoints may use a carbapenemase testing sort of as a supplement to identify epidemiologically concerning gram-negative bacteria. So in 2016, about 464 of all the U.S. hospitals that were using old breakpoints, so just those using old breakpoints, they reported not performing the carbapenemase testing. And similarly in California, almost half of hospitals using old breakpoints reported not performing carbapenemase testing. So that also shows another gap in some of the clinical microbiology testing capabilities. Another aspect that the survey goes into is about how the laboratory reports results if a carbapenemase is detected. Of course, they only ask those hospitals that indicate that they do carbapenemase testing. And the majority changed the susceptible carbapenem result to resistant, if that's a situation that applies. So I think one of the primary reasons for doing this is to discourage the use of a carbapenem when treating that patient. They've been identified as having one of these carbapenemases, and so the lab essentially changes all the results to resistant, even if technically in the antimicrobial susceptibility testing step, maybe one of the carbapenems, for example, may have been susceptible. 28% of hospitals that do this reported that they just report the carbapenem MIC results as they are and don't necessarily edit them. And then 8% referred to that they don't change any interpretations in carbapenems because the test is used primarily for epidemiologic and infection control purposes. And that's something I'll go into a little bit more as well, what that means to use this test for epi and infection control purposes. So one of the questions that was not specifically geared towards the microbiology laboratory, but really about infection control practices at the hospital was about whether the facility routinely performs screening testing, whether culture or non-culture based, for CRE. So this would be, do you screen any patient population for the presence, being colonized, not necessarily infected, but colonized with carbapenemase, or with, I should just say, carbapenem-resistant CRE. So 88%, the vast majority mentioned doing no screening cultures for CRE. Among the 12% that do, they were able to check multiple answers here, but some did admission screening of all patients, some only when there were what we call epidemiologically linked patients of known CRE cases. That would be, maybe a roommate of someone who you just identified someone as having a CRE infection, so maybe we'll go ahead and screen their roommate, for example, for CRE as well to determine if possible transmission did occur. There's also admission of screening everyone upon admission of certain high-risk patients. This could include patients with healthcare exposures outside the U.S. in the previous 12 months, as well as patients that are on ventilators. And finally, the other category was about patients admitted to high-risk settings, such as the ICU. Overall, the numbers, were not that high for hospitals that routinely do this type of testing. So one of the final things I wanted to mention before moving on was that CRE colonization testing is available at ARLN. And similar to how we talked about targeted surveillance testing earlier as a free service where they basically help send materials to you, the West Regional ARLN offers CRE colonization in cases where a patient or resident with CRE is identified. So essentially when there are some concerns for transmission. This would be, epidemiologically linked to a previously identified CRE case, such as a roommate, maybe people residing on the same unit, maybe people that have had similar, healthcare exposures, for instance, duodenoscopes, if that's a possible route of transmission, definitely been implicated before. And then when there is sort of, an outbreak or cluster investigation, we work a lot with ARLN on doing a point prevalence survey, meaning really just doing a screening of really everyone on that unit. And, I'll mention that the screening, there's a number of different ways to do colonization screening, but this particular service is really focused on rectal screening. So they send out the swab kits, and they're collected and then sent back immediately within a day or two to ARLN, and then there's very quick turnaround in terms of results. So if you're interested in accessing this free testing service, just please email us at this email listed here, or you can always just follow up with me directly. So without any further ado, I'll go ahead and turn this over to Stephanie to discuss some of the results and tests available at MDL.
All right, thank you very much. Good afternoon. My name is Stephanie Barmitis. I'm the Section Chief for the Microbial Diseases Laboratory, MDL Foodborne and Waterborne Diseases Section. Today, Dr. Zhang, Dr. Sylvester, and I will be giving you a summary of the carbapenem-resistant Enterobacteriaceae, CRE, and carbapenem-resistant Pseudomonas aeruginosa, CRPA, testing performed at MDL from August 2017 through October 2018. In 2011, MDL began offering a lab-developed, real-time qPCR test to detect the carbapenemase gene, KPC. KPC is the most common carbapenemase reported in the United States. In 2013, that test was replaced with a lab-developed real-time qPCR test to detect KPC and the additional carbapenemase gene, NDM. In August 2017, MDL significantly increased their CRE testing capacity and began offering molecular CRE, CRPA, testing using the Cepheid Expert carba-r, which detects 5 carbapenemase genes, KPC, NDM, VIM, IMP, and OXA48. And MDL began offering phenotypic CRE, CRPA testing by the Modified Carbapenemase Inactivation Method, or MSIM. This testing is distributed between the MDL Foodborne and Waterborne Diseases section and the Bacterial Diseases section. Today, we will be sharing with you the results of the molecular and phenotypic CRE, CRPA testing performed by MDL from August 2017 to October 2018. Following introduction of the molecular expert carba-r and phenotypic MSIM testing, we had an approximate doubling of the CRE and CRPA submitted to MDL for testing. I would like to now go into more detail on the results of the 325 CRE and 105 CRPA that MDL received for testing between August 2017 and October 2018. This chart is showing you a breakdown of the organisms received for testing. The three predominant Enterobacteriaceae received were Klebsiella pneumoniae, Enterobacter species, and Escherichia coli. Submissions were received from 18 different county public health laboratories. Submissions from Alameda, Orange, San Joaquin, Santa Clara, Riverside, and San Bernardino accounted for 89% of the CRE, CRPA isolates received for testing. The submissions came from a total of 128 different California healthcare facilities. When CRE, CRPA isolates are received by MDL, the species identification is verified by MALDI-TOF or VITEC. Next, rapid molecular testing is done using the expert carba-r. If a carbapenemase gene is detected, the results are reported. If no carbapenemase gene is detected, phenotypic testing is done using the NSHN. This testing is performed to test for the presence of a carbapenemase gene not detected by the expert carba-r. If a submitter has already performed molecular testing on a carbapenem-resistant organism and failed to detect a carbapenemase gene, MDL will not repeat the molecular testing, but will instead perform phenotypic testing following isolate ID confirmation. Let's now specifically discuss the molecular detection work. The expert carba-r detects and differentiates gene sequences for the carbapenemase resistance genes KPC, NDM, VIM, IMP, and OXA48-like. These are the 5 most common carbapenemases worldwide, the big 5. The BLA designation is the gene name, which is an abbreviation for beta-lactamases, specifically carbapenemases. The carbapenemase associated with each gene is included in parentheses. Something important to note is that there are multiple variants of each carbapenemase gene. They are functionally equivalent, but can have slight differences in nucleic acid sequence. Unfortunately, not all variants of the big 5 carbapenemases are detected by the expert carba-r. The information in this table is taken from the Cepheid Expert carba-r 510K substantially equivalent documents. I've included the testing results for IMP. What you can see is that there are a number of IMP variants that the expert carba-r has been shown to detect, 1, 2, 6, 10, and 11. But there are also variants which it cannot detect, 7, 13, and 14. Additionally, there are several variants where there is not sufficient laboratory testing to know if they can be detected. So, a result of a gene non-detect by the expert carba-r does not actually preclude the presence of that gene. A total of 255 CRE were tested by the expert carba-r at MDL. 124 of these were positive for the carbapenemase gene KPC, and 39 were non-KPC CRE. Those 39 isolates were positive for IMP, NDM, OXA48, and VIM. 4 of the isolates encoded both NBN and OXA48. The 92 isolates that were negative by expert carba-r were transferred to the MDL Bacterial Diseases section for phenotypic testing by MSIM. The phenotypic testing is important because it allows us to determine if a carbapenemase gene not detected by the expert carba-r could be present. This is a summary of the expert carba-r testing results for the CRPA received. 90% of the isolates were expert carba-r negative for a carbapenemase gene. The remaining 10% were either VIM or KPC positive. All of the expert carba-r negative CRPA isolates had phenotypic testing performed by MSIM. I would now like to turn the presentation over to my colleague, Dr. Peng Zhang, who will be discussing the phenotypic testing by MSIM.
Thank you, Stephanie. So this is Peng. I'm the section chief in bacterial disease section at MDL. So first, I'd like to briefly review the phenotypic testing. Phenotypic testing is to detect the production of any type of carbapenemases, and it does not provide information on which genes or mechanism that confer the resistance. However, like Stephanie mentioned, it becomes essential when the antimicrobial resistant isolates carry genes other than the gene target included in the molecular testing, such as expert carba-r. So in conjunction with molecular tests, phenotypic tests could identify rare or new antimicrobial resistant mechanisms. Three phenotypic testing methods listed on the slides are currently recommended by the Clinical and Laboratory Standard Institute, or CLSI. Each one has its pros and cons. Carba-MP is a rapid method for Enterobacteriaceae and Pseudomonas aeruginosa, but requires a special reagent and has poor sensitivity for detecting oxalate carbapenemases. MSIM was validated by multi-centers, has proved to be a sensitive and specific method for detecting carbapenemases produced by CRE and CRPA, and no special reagent is needed, but it has longer turnaround time. eSIM is a new addition in the CLSI 28th edition. When performed together with MSIM, eSIM can differentiate serum carbapenemase from methyl beta-lactamase in Enterobacteriaceae. No special reagent are needed. However, it is only valid when MSIM result is positive, and similar to MSIM, it has longer turnaround time. So MSIM is the phenotypic testing that we're currently offering in MDL. So how does MSIM work? Well, a meropenem disk is incubated in the bacterial suspension from a tested isolate. The carbapenem in the disk could be inactivated or hydrolyzed if the isolate produces carbapenemase. Then the inactivation of meropenem can be detected by transferring and incubating the disk onto a plate with the meropenem-susceptible indicator E. coli. If the tested bacterial isolate is a carbapenemase-producing organism, meropenem in the disk is inactivated and allows the indicator E. coli to grow. There will be no zone or very small inhibition zone around the disk. On the other hand, if the tested isolate is a non-carbapenemase producer, the meropenem disk will retain its activity and be able to inhibit growth of E. coli indicator. As a result, we'll see a good size of inhibition zone around the disk. So how do we interpret the MSIM result? Depending on the size of the inhibition zone and the presence or absence of the colony within the zone, we can determine the tested isolates as either carbapenemase positive, negative, or indeterminate. More detailed information can be found in the CLSI M100 28th edition. So as Stephanie mentioned earlier, expert carba-r only detect big 5 and a certain variant of big 5. So in order to detect unusual carbapenemase, MSIM, a phenotypic test was performed on total of 255 CRE and CRPA isolates. These isolates are negative by expert carba-r or other molecular test. These isolates were either transferred direct from internally or direct submission of county labs. Out of 158 CRE isolates tested, 9 isolates were indeterminate. 125 are negative by both MSIM and molecular method, and 26 isolates have discordant result between phenotypic and genotypic testing. They are negative by molecular methods, but positive by MSIM. So the identification of these isolates with the discordant result was notified to CDC, and these isolates were sent to Washington State or regional lab or CDC for further testing. So this slide shows you the CRPA isolates that are carbapenemase negative, gene negative by molecular testing. Of 97 CRPA isolate tested, we found one isolate is indeterminate by MSIM, and the 94 are negative by both MSIM and the molecular methods. We identified only 2 isolates have discordant result between phenotypic and the genotypic tests, and they are negative by molecular methods, but positive by MSIM. And again, the alert for the discordant result was sent to CDC, and this isolate was submitted to Washington Regional Lab or CDC for further testing. This is the summary of CRE and the CRPA testing in MDL, combining both expert carba-r and MSIM. We tested total of 430 suspected CRE and CRPA and identified 196 isolates that produce carbapenemase. When break down this isolate into CRE and the CRPA, we found 325 isolates are CRE and 105 isolates are CRPA. And 186 isolates are identified as CP-CRE, and only 10 isolates identified as CP-CRPA. So now I'm going to switch the gear to talk about sample submission. Isolates submitted for testing should be suspected CRE and CRPA isolates. So please send isolates that are resistant to at least one carbapenem, and please include antibiotic susceptibility test result with the submission. We encourage to avoid sending multiple isolates from same patient collected on the same day. For isolates that have already been tested using molecular methods, only send those tested negative. No need to submit the positive isolate for confirmation. But if there's a need to do so, please contact HAI program and MDL for approval. And we also asked to make sure the field for original submitting facility is completed. This piece of information is very important for the epidemiologist to track the antibiotic resistance and effectively control the spreading of AR strains. Pre-approval is requested from CDPH HAI program for submission of organisms other than Klebsiella species, E. coli, Enterobacter species, and Pseudomonas aeruginosa. And this is because HAI program may need additional IP information. This slide to summarize the current CRE, CRPA testing availability and the forecast of new testing in the near future. MSIM is available in bacterial disease section, expert carba-r, and laboratory-developed qPCR available in food and water disease section. MDL also offers whole genomic sequencing in the core lab, which will be presented next by Dr. Matthew Sylvester. For the future testing, soon BDS will be available to offer AST service using Sensitive Titer platform. We also have planned to implement real-time PCR assay to detect colistin-resistant genes. Now I'm going to pass the talk to Dr. Matthew Sylvester.
Thanks, Pong. So I am a research scientist in the core laboratory where we do whole genome sequencing. And I'll be talking about carbapenemase gene detection and genetic relatedness by whole genome sequencing. Next slide. So the core laboratory unit in the MDL performs whole genome sequencing for a variety of bacterial pathogens, including those implicated in healthcare-associated infections. The whole genome sequencing test on the Illumina MiSeq is CLIA validated, and it can be used for species confirmation or identification of antibiotic resistance genes, and either establishing or ruling out relatedness when there is a potential outbreak. It can also be used for in silico multi-locus sequence typing or virulence gene detection, both of which can be useful in specific situations. Carbapenem-resistant bacteria such as CRE, CRPA, or carbapenem-resistant Acinetobacter are not routinely sequenced as part of the workflow at the MDL, but we do perform whole genome sequencing when there is a potential cluster or outbreak. As such, we work closely with the HAI program to determine when whole genome sequencing will be particularly useful for epidemiological purposes. Next slide. This is an illustration of an outbreak where whole genome sequencing helped to identify both a rare carbapenemase variant as well as the likely route of transmission. The 4 cases of carbapenem-resistant Acinetobacter were identified at an acute care hospital, though only 2 of those isolates were available for whole genome sequencing. The index patient, for which we did not have an isolate, was transferred to an LTAC hospital, where a 5th patient was subsequently identified approximately 1 month later. An isolate was available for this patient, and it was also submitted for sequencing. Of note is that although the isolates were known to be highly resistant to carbapenems phenotypically, a putative genetic determinant was not known. Next slide. We first confirmed that the species was Acinetobacter baumannii. This was important because one of the isolates was submitted as Acinetobacter baumannii or hemolyticus. In most cases, we determined the species using a genome-genome comparison between our isolate and a reference database of sequences. Next slide. Next, we predicted antibiotic-resistant genes from whole genome sequencing. The tool utilized searches a database of antibiotic resistance gene sequences and finds matches. From this, we found the gene for OXA237, which is a rare OXA variant with carbapenemase activity. OXA237 was initially identified in a single isolate from California, and it has also been found in outbreaks in Oregon and Montreal that occurred between 2012 and 2014. Although we had phenotypic results indicating carbapenem resistance, it is interesting to note that the expert carba-r system would not have detected OXA237, indicating the utility of whole genome sequencing, and we have phenotypically positive PCR negative results. Next slide. We found that all isolates were sequence type 208, and the isolates differed by only 1 to 4 single nucleotide polymorphisms, or SNPs. So that is, across a genome of approximately 4 million bases, only 1 to 4 were different, suggesting that the isolates were closely related, as shown in the phylogenetic tree here. And then if we refer back to the diagram indicating patient flow between the two facilities where the isolates were obtained, we can identify a route of transmission whereby patient 1 was transferred from the acute care hospital to the LTAC hospital where patient 5 was subsequently infected. This was able to be determined even though patient 1 was not sequenced because EPI information was available. Interpreting sequencing results in the context of EPI data is always critical. To summarize, whole genome sequencing was able to determine that the highly drug-resistant Acinetobacter baumannii carried the rare OXA237 carbapenemase gene, and that isolates collected months apart from two facilities were closely related. Next slide. Sequencing also informed EPI follow-up. The index patient was transferred to a skilled nursing facility, and the local health department was able to follow up and coordinate this transfer. Patient 5 was transferred to an acute care hospital, which was also notified. Next slide. If you believe that whole genome sequencing may be useful for a particular isolate or outbreak investigation that you're working on, please contact the HAI program. We do have limited testing capacity, so prior to sending isolates to the MDL for whole genome sequencing, facilities or public health departments must obtain prior approval from the HAI program by emailing hai-program@cdph.ca.gov. They will request additional epidemiological information to determine if whole genome sequencing is feasible at that time. And with that, I'll turn it back over to Sam.
Great. Thanks, Matt. That was really nice overview of whole genome sequencing here at MDL and how it can be useful, especially in kind of HAI-related outbreak investigations and just really monitoring the overall trend of antimicrobial resistance, identifying some of those variants that I think Stephanie was talking about earlier that just can't be identified by the Cepheid carba-r. So I think this is really helpful, so thank you for that. We now, I think we've made really good time. We have about 10 minutes left. And for questions, generally for these California AR Lab Network webinars, we've found it most useful when people just type all their questions into the chat box, and the presenters will go ahead and answer them. Also note that a copy of the slides and recording of the webinar will be posted on the CDPH HAI program website, and all webinar participants will be notified when they're available. I know Lynette asked that, or mentioned this earlier at the beginning, but I know will we get a copy of the slides is always the most common question, so I thought I'd address it twice. And I also wanted to know, for any questions about this presentation, the methods, or really about ARLN targeted surveillance that we discussed earlier, please go ahead and get in touch with the HAI program. So one of the first questions I see in the chat box is from someone just about how does one access the ARLN lab for testing services. And that's a good question. There's actually kind of a complicated workflow. Most of the submissions that we talked about today, that Peng was talking about, come directly from the state public health lab or also the LA County Public Health Lab. And then they go directly to Washington. Specifically for that targeted surveillance program, the one looking at highly resistant Acinetobacter and cephalosporin-resistant Klebsiella E. coli, and of course Candida species. That particular program involves direct submissions from the clinical lab to the Washington ARLN. But we still go ahead and coordinate that. With the HAI program is really probably the main go-between. So we would recommend just getting in touch with us. We have a lot of materials we can share about targeted surveillance. And we're happy to, our typical method when recruiting laboratories has been to kind of set up a conference call that everyone, usually the EPI is on the phone or the infection control, as well as, of course, the micro folks as well, because it's really just about not just the logistics, but also why is this important for your hospital? What is the value added here? As far as the colonization testing, CRE colonization testing I was mentioning, that's also directly between the facility and the in the Washington West Regional Lab. Sometimes in some cases, especially with skilled nursing facilities, the local public health department or lab will actually go out, collect the specimens or oversee the specimen collection and send it themselves. But 9 times out of 10, it's really direct submission from the facility to the West Regional ARLN lab. But again, just contact the HAI program, and we're happy to set that up, make those connections. There's all kinds of forms that we need to fill out with people's information, et cetera. Another question that we received was just what type of testing is done for screening, and where do you recommend that test be done? So, screening tests for CRE specifically, I guess there's sort of 2 different scenarios. One is kind of in response to an outbreak cluster or really any sort of suspected transmission event. That would be, the case I mentioned earlier about the roommate of someone who was just identified with a CRE infection. And then there's the kind of routine testing of, some facilities have decided all patients coming to their ICU are going to be tested for CRE, something like that. So in general, the testing is, the type of testing is rectal swabs. Now, if these are ventilated patients or have tracheostomies or something, then perhaps it could be sputum samples. But in general, we're talking about rectal swabs, and they can be submitted directly to your own clinical lab that can do a culture and work it up and organism identification and AST, et cetera, or it can be sent directly to ARLN, which does that kind of rapid testing, just tells you whether or not one of those big 5 carbapeenamases is present. So I think that hopefully answers that question about what is the type of testing that's done for screening, and where do we recommend that test to be done. It's really, we offer multiple options, and it's really up to the own facility, their own particular situation to decide what is the option that works best for them. Another question was, if we get susceptibility from the VITEC2, where the expert system flips a carbapenem to resistant, should we submit that isolate for carbapenemase testing? So I'm looking over to my MDL colleagues who might be able to better answer that. I mean, if we get the susceptibility testing from the VITEC2 and then it flips the carbapenem to resistant, meaning I believe that it is registered as resistant, can it be submitted to us? The answer I would say is if it's an enterobacteria, if it's E. coli, Klebsiella, Enterobacter species, or Pseudomonas aeruginosa, that can be submitted to us for carbapenemase testing. Again, this is voluntary, and it takes place, this always occurs through your local public health lab. So it's not something you submit directly to us. It's submitted through the local public health labs. We have the forms and all the know-how and whatnot. We're happy to coordinate that type of testing. And we encourage folks, when you have an epidemiologically concerning CRE, in my mind, a Klebsiella that's resistant to a lot of classes of drugs, that's very concerning. And so we would definitely recommend accessing carbapenemase testing. Is that anything else to add? Okay. So the next question is about turnaround time by ARLN. And I actually wanted to also ask about turnaround time by MDL as well. Turnaround time by ARLN is different based on what these type of testing you're asking about. So for targeted surveillance testing, they do a good job with pretty rapid turnaround testing for Acinetobacter, for some of these rare carbapenemases, usually OXA type carbapenemases. Matt just presented on a rare carbapenemase. As far as antifungal susceptibility testing on all Candida species that are submitted to them, that has a little bit more of a turnaround time, but previously they were sending it out. Now they have capability on site to do it, but it still, I think, takes a little bit of time. So if people are asking about sort of a clinically relevant turnaround time for that antifungal susceptibility testing, it that could be pushing it a little bit. But usually within, we're mainly talking about within 24 to 72 hours. For colonization screening, that occurs pretty rapidly. Usually within 24 to 48 hours, we have a result for colonization screening. So, and that's usually related to suspected or potential transmission. So hopefully that answers that. Unfortunately, when it comes to ARLN, there's a lot of different testing types, so the turnaround time differs. For MDL, what would you say? I know you talked a little bit about the algorithm of where things are tested and when. What is the, from the time we receive the isolate, what is the anticipated turnaround time for any sort of carbapenemase testing, whether molecular or phenotypic?
Right. Again, this will depend on the type of testing that needs to be done. Of course, we do identification, verification on all isolates that are received. If molecular testing has not been performed, that will be performed first. And if we do identify a non-KPC carbapenemase gene, we do immediately send out a preliminary report to the submitter to make them aware of that. However, if a gene is not detected or KPC is detected, then a normal report will be mailed out, and phenotypic testing will be done on the ones that are negative by expert carba-r. And is there anything you'd like to add on?
Yeah. So the phenotypic testing, which is the MSIM, normally we have turnaround time between one week and 2 weeks. The reason is because it has, just like we mentioned, the weakness of this testing is turnaround time. It has a longer turnaround time.
Great, thank you. One of the next questions comes from one of our skilled nursing partners. Do you suggest that skilled nursing facilities do colonization testing, I assume CRE colonization testing, on admission from an acute care hospital? And that is a great question, and I wish I had sort of a one clear-cut answer for you. But the answer is it really depends. In terms of doing admission screening, a lot of facilities, acute care or otherwise, have decided, we're going to focus in on a specific patient population, and that we deem as sort of being at high risk. So, you do have, it would be appropriate in some situations for a skilled nursing facility, especially maybe one that's caring for such high-risk patients, such as a ventilator skilled nursing facility or one that provides subacute care. It would make a lot of sense, I think, for them to do CRE colonization testing upon admission, and we could help coordinate that with ARLN, sort of a special circumstance, but we could definitely help make that happen and retesting for carbapenemase detection. Just in general, unless the acute care hospital has been identified as maybe having an ongoing issue with having CRE positive residents or patients, or, when you say acute care hospital, that would include a long-term acute care hospital, which tends to just have higher rates of MDROs in general. This is well described in the literature and has been our experience in California as well. So perhaps a nursing home would screen all patients, residents coming through the door that came from a particular long-term acute care hospital. So unfortunately, there's not one size-fits-all answer, but I think it's definitely something that should be considered, especially for these residents coming from, high-risk situations. It could even be just residents who have a recent history of healthcare outside the United States. That's probably our highest risk overall group. Of course, it's hard to know that upon admission, but I do think it's a good idea for both nursing homes and acute care hospitals to really think hard about the patients that are coming into their facility and how to best make sure that they're detecting MDROs like carbapenemase-producing CRE. So thank you for that question. That is all the questions I'm seeing. Let me scroll back up. All the questions I'm seeing currently at the moment. It is 12 o'clock, so I think it is a good time to end. I didn't mention at the end of this slide, if you're interested in if you were not kind of on the original mailing list for this webinar, and you haven't already done so, you can sign up for the California AR Lab Network. That's really what this webinar series is part of, the Lab Network. And the link to that contact list is included here. And we can give you information on all future webinars. We usually do about 4 a year or so. So unless people have additional questions, which they can always, feel free to email the HAI program, email me directly, just let us know what works best for you. But we're happy to, follow up and answer any questions people might have. And of course, you'll be hearing from me soon about slides that are posted online, as well as a link to a recording. So with that, I'll turn it over to Lynette.
Thanks, Sam. And thank you to the presenters for today's informative presentation. A copy of the slides will be posted to the CDPH HAI program website soon. This now concludes our webinar. Have a pleasant afternoon.